When eye drops can no longer control glaucoma, we have a mechanical problem. The eye is constantly producing fluid, but the internal drainage plumbing is severely blocked, causing pressure to build and threaten the optic nerve. For decades, the default surgical fix for this has been the trabeculectomy. By creating a tiny trapdoor in the sclera, surgeons allow fluid to escape and relieve that pressure. But a trabeculectomy relies entirely on manipulating the eye's natural tissue. If the body heals that surgical trapdoor too well, the drain closes. And if a surgeon has to go back and do a second or third trabeculectomy, the eye's fibroblasts are already primed to scar, meaning each subsequent surgery fails faster than the last. That specific biological vulnerability led to the development of glaucoma drainage devices, or tubes. Originally, doctors only reached for a tube when a trabeculectomy had already failed. To figure out if a tube should actually be the primary choice, we need to compare these two options across three specific metrics: medication independence at 1 year, survival rates at 5 years, and the post-operative logistical effort. Making the right call for a patient ultimately comes down to prioritizing either an early release from eye drops or securing a physically durable drain that will last for years. A trabeculectomy works by bypassing the eye's blocked internal drain. The surgeon cuts a delicate flap in the sclera, allowing aqueous fluid to seep out into a small blister under the conjunctiva, called a bleb. The moment you make that cut, the eye's immune system responds. Fibroblast cells rush to the site and multiply, creating fibrous scar tissue. That natural healing response is exactly what causes a trabeculectomy to fail. To prevent this, surgeons apply antimetabolites, like mitomycin, directly to the tissue during the procedure. This effectively poisons the fibroblasts, freezing the healing process in its tracks. While that keeps the trapdoor open early on, applying anti-scarring chemicals creates a long-term liability. The resulting tissue is permanently compromised. Years later, patients can develop dangerously thin blebs that leak fluid and open the door to severe, vision-threatening infections. This biological risk is highly magnified in younger patients, whose healing responses are naturally robust. The same goes for anyone who has had prior eye surgery. Their fibroblasts are highly reactive and ready to aggressively scar down any new incision. Because a trabeculectomy relies on outsmarting the eye's dynamic healing biology, success depends heavily on surgical nuance. It's an intricate art rather than a standardized mechanical fix. Glaucoma drainage devices solve this biological problem with hardware. A silicone tube is inserted directly into the anterior chamber, bypassing the active scarring zone at the limbus and diverting fluid to an external plate sitting further back on the eye. The plate acts as a physical barrier, so the conjunctiva cannot scar tightly to the underlying tissue. There are two main types of these devices. A non-valved implant, like the Bearvelt, expands the surface area of that external plate. Clinical data suggests that a larger plate surface usually results in lower overall intraocular pressures. But a non-valve tube is basically an open pipe. If you let fluid flow instantly, the eye's pressure will drop to dangerous, near-zero levels. Surgeons have to physically tie it off with a dissolving suture, which means the patient doesn't get immediate pressure relief until that suture releases weeks later. These non-valve designs are highly replicable and increasingly accessible worldwide. Institutions in India manufacture variants like the ADI, bringing the cost of the hardware down for global surgical outreach. The alternative is a valved implant, like the Ahmed device. It includes a built-in flow restrictor. Because it controls the outflow rate immediately, surgeons don't have to tie it off, giving the patient instant pressure lowering. The downside is that the surrounding tissue is immediately exposed to highly inflamed postoperative fluid. That inflammation often provokes a thicker healing capsule over the plate, which can result in slightly higher overall pressures long-term. Both tube designs share the same core philosophy. They abandon the subtle physiological manipulation of a trabeculectomy in favor of a physically enforced drainage space. To measure exactly how that physical hardware holds up against a traditional trabeculectomy, researchers at several major institutions conducted the TVT study, tracking patient outcomes over 5 full years. This chart shows the medication burden for both patient groups over time. At the 1-year mark, the trabeculectomy line drops significantly lower than the tube line. If the sole goal is getting a patient completely off all glaucoma drops, a trabeculectomy is highly effective in the first 12 months. But watch what happens as the timeline advances. By years 3 to 5, the trabeculectomy medication line steadily climbs back up until it matches the tube group. The initial advantage of being drop-free disappears entirely. Now, looking at the surgical failure rates, we see a clear divergence here. Late scarring causes the trabeculectomy failure rate to climb steadily over 5 years. The tube group's failure rate, protected by that physical silicone plate, stabilizes and stays relatively flat. This durability matters intensely if a patient later needs a cataract removed or a cornea transplant. The severe inflammation of those subsequent surgeries will typically cause a working trabeculectomy to scar shut. A silicone tube easily survives that trauma. The data confirms the trade-off. A trabeculectomy wins the short game for early medication independence, but drainage devices win the long game for absolute durability and stress tolerance. Clinical data is only half the equation. The final decision often rests on the real-world logistics and the post-operative return on investment for the patient. A trabeculectomy requires intense babysitting. To keep that delicate blev alive through the first 2 months, the patient endures multiple clinic visits, specialized suture cutting, and frequent steroid injections. Drainage devices bypass that entirely. If a patient lives 3 hours away or has limited resources to come in for weekly follow-ups, a tube is logistically superior. Once properly installed, it works independently of heavy post-operative maintenance. Patient profiles dictate the surgical path. High risk factors like youth, prior surgeries, or distant geography route directly to a tube. Conversely, trabeculectomies are reserved for older patients needing 0 early eye drops who can attend intense post-operative follow-ups. For complex clinical cases or difficult logistical realities, the glaucoma drainage device has evolved from a secondary backup into the definitive primary choice.